Alright team, welcome to the next video of our series to learn medical English and cardiology. I have a great case for you today. I just want to remind everyone that in this series, I go a little bit slower. The pace is just a bit slower so you can practice the terminology, how to present these cases, and understand medical English in addition to learning cardiology. So this is the case of a 68-year-old woman. Unfortunately, she has lung adenocarcinoma, and in the last 3 weeks, she's been having dyspnea on exertion. So she went to her oncologist with these symptoms, and she said that over the last few weeks, she has dyspnea in climbing 1 flight of stairs or walking half a block or 1 block. And in addition, she has some pleuritic chest discomfort at the side of her cancer. I believe it was on the right side. And on this EKG, we have an interesting finding here. The voltage on the QRS is low. All right, so when we look at this in the precordial leads, V1 through V6, okay, all the QRSs and all of these leads, they have less than 10 millimeters. So the height of the QRS, all right, here in V5, in V6, in all the leads, V1 to V6 has less than 10 millimeters. So that's one of the criteria for low voltage. The other criteria is in the frontal leads here. You have the voltage less than 5 millimeters on all the leads. So this patient has low voltage on the ECG. All right, and then especially as we compare to her baseline EKG a couple months before, you can see that the voltage was much higher here, was about 15 millimeters in V5. So she had a decrease in the voltage. And what causes this? Anything that is in between the heart and the leads on the outside can decrease the voltage. It could be adipose tissue in someone who is overweight. Okay, it could be fluid in someone who has a pericardial effusion. It could be amyloid in someone who has cardiac amyloidosis. So anything that's between the heart and the leads could decrease the voltage. In this case, we will see in a second that it was fluid. So her oncologist sent her to have a cardiac echocardiogram, which we see here. And on the echo, we see this large pericardial effusion that's fluid in the pericardial sac. All right. And now that we know that she has an effusion on echo, this question comes up. Does this patient have cardiac tamponade? And I can tell you, if you're going to be an internal medicine doctor, if you're going to be a cardiologist, if you're a surgeon or anesthesiologist, sometimes this comes up. This is a very common clinical question. If you're in the ER, you're going to have this question all the time. You see a patient, the patient has an effusion, has symptoms of heart failure. Does the patient have cardiac tamponade or not? And it's important to understand that a pericardial effusion and cardiac tamponade are 2 different things. Patients can have a large pericardial effusion with no tamponade. They can have a small pericardial effusion and have tamponade. Obviously, the bigger the size of the effusion, more likely that the patients will have tamponade, but they are not synonyms. You have to evaluate the patient with an effusion whether they have tamponade. They may or may not have cardiac tamponade. So what defines pericardial tamponade? It's when the fluid in the pericardial sac, if it's small, medium, or large, compresses the cardiac chambers. It increases the filling pressures around the heart, so the heart has a hard time filling. There's impaired filling of the cardiac chambers, and if this leads to hemodynamic compromise, to hemodynamic derangements, that's called pericardial tamponade. Okay, so you need all those things. You need the fluid, small, medium, or large, in the pericardial sac, but it also needs to exert enough pressure on the heart to cause impaired filling and hemodynamic compromise for you to say that the patient has pericardial tamponade. And how would we know? There are hemodynamic signs of this, okay? So if a patient can't fill the heart, they're not going to have a cardiac output. Every time the heart ejects, it's going to be a little bit only of cardiac output because the filling is impaired. So the way to compensate is only by increasing the heart rate. So then these patients can have sinus tachycardia because they are in a state of hemodynamic compromise. They're trying to maintain cardiac output, and they can only do so by increasing the heart rate. All right, another situation, elevated jugular venous pressures, okay? When you have cardiac tamponade and that thing is pressing on the right heart, you're gonna have elevated JVP. Another sign is hypotension, but hypotension is late in the disease course, okay? And then there's another finding, which is pulsus paradoxus. Pulsus paradoxus is very important. Pulsus paradoxus is the manifestation of what we call ventricular interdependence. Ventricular interdependence means the following. You have fluid inside the pericardium. Fluid impairs ventricular filling. That means that to fill one ventricle more, you have to fill the other ventricle less. So this happens when a patient takes in a deep breath. When that happens, you have more blood going into the right side of the heart. The right side pushes the interventricular septum to the left and decreases left-sided filling. So with less filling of the left ventricle, you have a decrease in systolic blood pressure. So pulsus paradoxus is the decrease in systolic blood pressure on inspiration by more than 10 millimeters of mercury. If the systolic blood pressure in systole is 110 on inspiration and 130 on expiration, that's a pulsus paradoxus of 20. A pulsus paradoxus more than 10 is a sign of pericardial tamponade, okay? And I'll teach you guys at another time how to measure pulsus paradoxus. And then I didn't write down here, but a very other important sign is any signs of hypoperfusion. If the patient has an altered mental status, if the extremities are cold, okay, obviously if they have low blood pressure, all of these are signs of shock, of hypoperfusion to the organs, and they are signs of pericardial tamponade. So going back to our patient and showing here some very interesting images, this is in diastole, guys. Look at this. This is the time in between the RR interval where we're in diastole. In diastole here, the right ventricle should be full. It should be expanded, okay? And this compression of the ventricle in diastole is a sign of elevated filling pressures in the pericardium. The pericardium is pressing down on that ventricle and causing the systolic compression here, which is characteristic, which is seen in cardiac tamponade. Another finding here is the mitral valve inflow. Okay, mitral valve inflow. This mitral valve inflow is another manifestation of what I explained already called ventricular interdependence. Okay, ventricular interdependence works like this. Filling of one ventricle compromises, decreases filling of the other ventricle because the space is limited. If you have a large effusion, to fill the right, you have to fill less the left. That's the way it works. So when the patients take a deep breath in, like they did here, for example, there's more flow to the right side, but we're not looking at the right, we're looking at the mitral here. When we're looking at the mitral valve, flow goes down in inspiration. On expiration, flow goes up on the mitral. So when this variation between systolic inflow and inspiration and systolic inflow, when this variation between diastolic inflow in the mitral valve in inspiration versus expiration is more than 25%, that's a sign of ventricular interdependence, and it's another sign that the pressures inside the pericardium are just too high. Okay, so that's called ventricular interdependence, this variability in mitral valve inflow in diastole, more than 25%. And another sign is when the IVC, the inferior vena cava, is just dilated and it doesn't move in inspiration. So in normal situations, when you're taking a deep breath, you ask the patient, take a deep breath in. Patient does a deep breath in. What happens is that IVC, the inferior vena cava, collapses or it decreases in size. And that's not happening here because the pressure inside the right heart, in the right atrium, in the right ventricle are just too high. The pressures are too high, so the IVC pressure never goes down. It stays up even when the patient takes a deep breath in and it collapses the vein. It doesn't collapse the vein. Normally, the vein should collapse. It should go down when you ask the patient to take a breath in, and that does not happen here. So going back to our patient, she has this clinical history, but then when we saw this echo, we took a look at her. Her blood pressure was normal. Her heart rate was not tachycardic. She was not tachycardic. She was saturating well on room air, and she did not have pulsus paradoxus. It was not above 10. Her extremities were warm, and her JVP, jugular venous pressure, was only mildly elevated, okay? 12 is only mildly elevated. So she had some signs of elevated filling pressures. The JVP was a bit high. We saw all the findings on echocardiogram of high filling pressures, the systolic compression of the right ventricle. We saw the variation in mitral valve inflow. We saw the inferior vena cava, which was not collapsing in inspiration. So all these findings, they say the pressures are high in the pericardium, okay? But the patient does not have an important hemodynamic compromise yet, because her blood pressure is normal. She's not tachycardic. She does not have pulsus paradoxus. Does that mean she doesn't have to have the effusion drain? No, she should still have it. She has symptoms of a pericardial effusion. It's a large pericardial effusion. There's signs of elevated pressures. It just means she doesn't have yet the hemodynamic compromise, okay, affecting heart rate, affecting pulsus paradoxus, which are situations where it's an emergency. If you have hypotension, if you have a patient that's very tachycardic, if you have a positive pulsus, those are situations where you need to hurry up to drain that pericardial effusion. So in conclusion, this patient had a large pericardial effusion. She had echocardiographic signs of cardiac tamponade, but no major hemodynamic compromise yet from cardiac tamponade. So we still did the drainage of the effusion because she was symptomatic, because of the findings on the echocardiogram, but she did not need to have an emergency drainage because of all the things I discussed with you. Okay, don't forget to download our free ebook. It's in Portuguese, not in English, but you can learn a lot of EKG over there. And here's my contact. Always a pleasure teaching you guys. Stay safe and send me messages with any questions. Take care. Bye-bye.